I would now like to introduce our first speaker, Dr. Qian, MD, PhD, a pain management physician and clinical professor of anesthesiology, perioperative and pain medicine at Stanford University. Dr. Qian is incredibly impressive. Just listen to what I have to say about him. Dr. Qian is highly respected for his work on developing novel therapies for various chronic pain conditions. His clinical interests include treatment of acute and chronic pain, with special interest in migraine headache, trigeminal neuralgia, glossopharyngeal neuralgia, hemifacial spasm, atypical face pain, cancer pain, back pain, joint pain, nerve pain, and others. At Stanford, Dr. Qian developed many advanced surgical and interventional technologies for his patients. He currently leads the CT-guided interventional pain program and is the recipient of Translational and Clinical Innovation Award at Stanford. With his deep interest in clinical innovation and translational medicine, Dr. Qian is the faculty professor and co-director of Stanford Wearable Electronics Initiative, otherwise known as eWear, and has been working with colleagues from engineering school to develop mini implantable nerve stimulator powered by wireless energy. Similar to a pacemaker for the heart, nerve stimulators are modulators for the nerves. Due to his passion for global health and leadership experience, Dr. Qian was appointed as the medical director of Stanford International Medicine Services, IMS, since 2016, where he has been working in collaboration with faculty members from all subspecialties and hospital administrations to help deliver care for international patients and promote international collaborations. Dr. Qian completed his residency and fellowship training at Stanford. Prior to that, he received his PhD degree in physiology and biophysics from University of Miami Miller School of Medicine, and went through postdoc fellowship through training in neuroscience at UCSF. Outside of the work he does at Stanford, Dr. Qian founded the Chinese American Physicians Society to foster his efforts in bringing medical knowledge internationally. Today, the society has more than 800 physician members from 50 states of the U.S. across 40 different subspecialties. Please join me in welcoming Dr. Qian.
Go make it a little higher. Well, good morning, everyone.
Let's remind everybody we have a timekeeper, Isha,
Okay,
and so she'll let you know.
absolutely. All right. Well, good morning, everyone. It is my great honor to be here at a place I have a deep love because my two kids are here in Berkeley for college. And thank you so much, Amy, Dr. Martaki, for organizing such a wonderful symposium. Really, congratulations. I came here last year as well, for the first one. I hope to attend your future events. And thank you, Charlene and Donna and everyone, and congratulations on making this, a wonderful event. I can imagine. I already did the pre-survey, and it's wonderful. Already looking forward to the whole day event. And Dr. Boyton, with your support, without your support, this wouldn't be possible. I also wanted to tell the audience that Dr. Mataki not only is serving the patient here in Berkeley, she is also a adjunct faculty at Stanford in my division, to serving the patients down there in the Bay. So congratulations on that. All right. So today I'm going to share with you my work at Stanford. The title is Breaking the Pain Cycle, my innovative therapies I developed over the past decade for headache and facial pain patients. Before I start, I wanted to say I have no relevant financial relationship to this topic. This I don't need to go through again, but you can take a quick look. So I want to start with my slides about sharing my understanding of pain and why pain hurts. So everyone in the audience have some experience with pain, but the key point is that pain is not related to an actual injury. In a lot of ways, hard for people to understand. I have patient coming in, they look normal, there's no injury, and they said my whole body hurts. That's a fibromyalgia patient, right? It has been very hard for this patient to seek care in many decades in the past because there's no identifiable cause. And people think that, in a way, they think they're crazy, but they're not, right? The reason is that for many, many years, we don't really understand why and what is pain. In Asian times, people think that pain may be related to your emotion. Maybe it's a manifestation of your things. The really modern scientific theory came in like 500 years ago by a French philosopher, Descartes. And he first time proposed that pain is a reflection of the degrees of injury you're suffering. That theory dominated for 400 or 500 years since that theory is the more injury you have, your body you have, the more pain you're experiencing. And it's associated with your strong emotion. And people think that the center of your pain and emotion is in the pineal gland. It's very interesting. So fast forward many years later, in 1965, a very famous two scientists, one psychologist, one physicist from Canada, they proposed this idea of gate control hypothesis. They have really laid down the foundations for our modern understanding of what pain is. Due to limited time, I wouldn't be able to go into the details, but after 30 years later, we start to realize that everyone would have a different experience of pain. So your pain experience and my pain experience, the brain circuit underlying is completely different. That came out was the theory of neural signature, i.e., you and I will have a different fingerprints for pain in the brain. The circuits responsible for the pain perception is different than everyone in the audience. And I think this is the theory we have now. We believe that pain is really an interplay between physiology, psychology, and sociology. So interplay of psychosocial, biological. So it's just not only, there's no readout, right? There's not like diabetes or hypertension have readout. We don't. Doesn't mean that it don't hurt, right? There's an interplay between the three components. This is very, very important. I think that laid down the foundation for integrative medicine as well, that we're not only going to treat you based on your symptom, but we're going to treat you as a whole. So the theory is right now, it is really based on the academic society. It is really an unpleasant sensory and emotional experience, okay, associated with acute or potential tissue injury or damage. So you can have damage, you can have no damage at all. And it is a combination of very unpleasant sensory, which is more of an objective, but also an emotional experience. So this is, in a way, it's a very subjective, right? It is subjective, so that's why we have a lot of debate. Should we ask you, how much pain do you have? What's the level of pain? 0 being no pain, 10 being the most pain. We ask that questions all the time. But does that help you to treat the patient? Not always, right? A lot of times that just misleads you. And this is kind of I want to start with this because I think this is a very important concept, that pain is an interplay between psychology, biological, social. It's very much subjective. And it's very different among each individual person. This is kind of lays down the foundation for all of us who treat pain. All right, so the type of pain. There's 4 major categories of pain if we dive down deeper into this. One is nociceptive, meaning that you got an injury, you got a cut, you got a surgery, right? You got a lot of information going on there. The neurons release substance, histamine, substance P, bradykinin, etc., and that generate a pain signal that transmit into your brain. Your brain starts to perceive the pain signal, and you can also modulate that whole process. So basically, transduction, transmission, perception, or modulation, 4 process for us to generate pain to this type of nociceptive. Same thing with inflammatory pain. Like you have osteoarthritis, you have inflammation going on, you had a pain. And neuropathic, if you have a chronic disease of diabetes or HIV, etc., it will affect your nerve, the nerve got swollen, neural damage, neuropathic. And the last category is none of that. It's not neuropathic, it's not inflammatory, it's not nociceptive neither. That is the central sensitized type of pain, i.e. like fibromyalgia or other types. So those are 4 major categories. Acute pain, chronic pain. Those are the 2 types of pain we talk about. Acute pain is more of a kind of a less than 3 months of duration. It's more of a kind of surgical related. It's more of a kind of a protective mechanisms your body wanted to, remind you to take care of your body. Versus chronic pain that by definition is more than 3 months. It's no longer protective. It has induced almost permanent changes in your brain, plasticity changes, etc., wire circuit changes. It becomes a disease state. There are a lot of impact for chronic pain in the country, right? Affecting 1/3 of our population. I'm sure you all know this, right? It affects the populations more than all those peoples together, by heart disease and cancers, metabolic disease together. And it costs our country more than $600 billion, directly and indirectly. Not to mention that #1 prescribed medicine in the country is opioids. Before COVID pandemic, the epidemic crisis we're talking about in this country is opioid crisis. It's more than 100,000 people die each year from unintentional overdose, not even intentional overdose. The problem persisted after the COVID crisis. We're just not paying that much attention to it. But the fact is that still thousands, hundreds of thousands of people die each year from that. And this is #1 reason people are out of work. Now, how should pain be managed? This is kind of the principles how we should manage it. Again, because it's a psychosocial biological process, you really cannot attack it from just purely a medical perspective, right? You need those 4 pillars. You can manage it with medicine, pharmacological, manage it with procedure, surgery, but more importantly, psychological part is essential. Also, you need to make sure they move around. There's a physical, there's occupational therapy as well. So that's where integrative medicines, brings in your unique experience that we want to make the patient move. We want to make sure we treat them as a whole. And that's why we have our acupuncture branch in our pain division, as well as our integrative medicine. We work with those providers very closely. I do not believe giving them a pill or giving them a procedure or giving them a surgery is the right way to treat our chronic pain patient. Unfortunately, in a lot of places in our nation, that's the way to do. That's a dominant way. That's why I think having this organization is very, very critical. And I hope we will continue to grow as a voice, as a leader in the nation. Pharmacological approach, I won't give you too much of details, but basically it's along the neuropathic pathway, right? If your finger got cut by a surgeon today, that cut is going to transduct into a pain signal. That pain signal is going to transmit through nerves, C fiber, A delta, go into dorsal horn, go into spinal cord, spinal thalamic, and that's called transmission. Go through thalamus and then project into various brain regions where we would perceive the pain. That's called perception. So transduction, transmission, perception. And then you can modulate. A soldier in the battlefield wouldn't even care if he lost a finger. While someone on the sea, if you got a little small cut in the finger, it will bother your whole lecture, right? That's your emotional status, your experience, your social, etc. will help you modulate. So pharmacological approach is really going through this whole process. The local anesthetics, the peripheral nervous system, blocking the brain and affecting the modulation, etc. There's many meds. We have more than 300 medication that I can use for my chronic pain patient. But this is the theory behind that. Procedure approach, I do a lot of procedures, and those are the procedures that I do. Nerve blocks, peripheral nerve stimulation, spinal cord stimulation, intrathecal pump, etc. But this is just a technique. Again, you cannot treat the patient as just a subject. You have to treat this patient as a whole. Very, very important. those are some of those procedures I do, but it helps to some degrees, to some extent, not all of them. So with that kind of a general concept, I want to share with audience my personal journey, why I picked headache, why I picked facial pain. I mean, I treat all kinds of pain patients, but my research, my clinical focus is really in the headache, in the facial pain sectors. And I will share with you my pathway of development, multiple interventions over the past decade, as well as my bench to bedside research. Headache and facial pain also affects millions of people in the country. For example, migraine patient. I don't know whether there's anyone in the audience have migraine, but there's 45 million people in the country have migraine. It's a chronic illness. It affects you throughout your life. It is number 3 reasons why people are out of a job, or out of work. They don't want to go to work because it hurts so much. Facial pain is the other 5%. For example, TMJ disorder is part of the facial pain. So I picked this not because it affects so many people, it's because a patient story. When I was a fellow more than a decade ago, this patient presented to me. She's in 30s with this horrible pain in the face that no one has an idea what's going on. She went through UC Davis, UCSF, many private clinics in the country, in this Bay Area, and there is no explanation to her. Well, people say she have a trigeminal neuralgia, a very, very painful conditions. People used to call it suicidal disease. But a lot of time we believe it's because there's a blood vessel in the brain that's touching on the trigeminal nerve. But her MRI is negative. There is no blood vessel touching on the nerve. She's also very young because the textbooks say it happens when you're 50, but she's only like 30s. And she doesn't know what to do. And she was on opioid medication and etc. She eventually came to me. I was a very young fellow at the time. Me and my attending diagnosed her. And we provided a test block for her. We confirmed her diagnosis. We were literally opening up the textbook in OR when we were doing the procedure for her, as we were not experienced. And many pain doctors in the country don't want to touch on this type of brain procedure because they have very high complication rate, and it's very complicated to do it. And the payment is not as good. Doing epidural injection, you can do 45 of them a day, or you can call for a day, and you get a lot of IVUs, right? For this procedure, you probably can only do 10 of them a day. You get very few IVUs. So that's just the reality. Anyway, a couple months later, she came back, and her dad came back to me and said that my daughter passed away, killed herself. This is her thank you letter for you because you and Dr. Carroll really cared about my daughter and then believed her story and diagnosed her. And furthermore, she donated her body to us and asked me and then Dr. Carroll to dissect her brain in the lab and say, are there any problems that was not visualized by MRI, and can we find out something for her? And we dissected, and there was nothing. And that was really traumatized to me. And made in my mind, I said that I wanted to work on this field. I want to provide service for this type of patient. And that's how I started my career. It was focused on the facial pain and the headache. I was very lucky because there are many colleagues who share my same passion, and we worked on together. I mean, again, what was missing for this disease is really the interventional part of it. Not only just the diagnosis, but also we lack of expertise, but we also lack of understandings for sometimes why this is happening, the trigeminal neuralgia. So with that kind of questions in my mind, I started to collaborate with radiologists, interventionists, neurosurgeons, and neurologists, as well as my colleagues in the pain division. That we started to develop various techniques. I started with collecting a lot of skull samples from our anatomy labs, and we tried to find out how we can get into the brain, find the target, block it or ablate it or do all the interventions. So long story short, we were able to identify a new approach for this type of patient that's very safe, also very, very effective, and we're able to publish our first study in 2014. And we have since educated many fellows, and they're going to Canada, various states of America, as well as international actually community from Philippines, Brazil, China, etc., that our program was able to teach them that how to treat this type of patient. And then we further advanced our treatment approach to, different kind of approach. Like for example, this is balloon compression that we published just recently. Then beyond that, I started to realize not only there is a trigeminal neuralgia patient out there in the community don't have a good effective intervention approach for them, but also a condition called glossopharyngeal neuralgia, which affects the cranial nerve number 9. Those patients have a terrible, terrible pain in throat that radiates to the ear. So oftentimes those patients will present to you, they're very low BMI because they can't eat. They have gastric tube, and they can't talk, they can't brush their teeth, their life quality is terrible. And we used to do this type of confirming test or block through a fluoroscopic X-ray, basically guided procedure, but the failure rate is very high. And also, the nerve comes out from the brain, travels in the neck area, where there's a vagus nerve, carotid artery right next to it. It's very dangerous without good visualization for you to do the procedure. So people are discouraged to do the procedure. So I developed this intervention that basically improved the success rate from 50% to 100% success rate, technology-wise. We're using a better visualization technique. So all the glossopharyngeal neuralgia patients from the Northern California, now entire California, they would come to me and my program for confirming test or procedure treatment if it's needed. If you have such a patient, you can reach out to me and I'll help them out. This is kind of how we do it. And then I also evolved from just treating the trigeminal neuralgia patient to a condition called hemifacial spasms. This is a disorder opposite to Bell's palsy, i.e. the facial nerve become very, very active and become overly active such that your face will start to involuntarily twitching and into a spasm. It's not painful at all because it's not pain nerve, it's a facial nerve, but it's very socially embarrassing. This is one of my patients as a grandma that she felt very embarrassed because whenever her grandchildren came, her face would start to twitch and her face will be grimacing like that. So I developed a procedure that can potentially help her. And I'll show you. This is the procedure I did in the lab, in the OR, and then let me see whether I can open up the video here. I really want to show you the video, but let's see how I can move But anyway, so I don't think I can open up the video, but this has video here. The patient who had a facial twitch, spasm, and after my interventions, immediately in the operating room, her face become normal. Maybe it's here. I don't know. I really want to show you guys.
Can I do the picture?
It's
a little player.
oh.
Can you click that player? Put the mouse over the picture, maybe.
Like this? No, it didn't show. On my slide it showed, but it's okay. I mean, you got an idea, the audience, right? So, involuntary kind of a spasm really was the procedure now become a very beautiful grandma, right? She's very, very happy. And she said, share this with your people and to see how this is, this changed my life. She's still alive and strong. So we published on Journal of Neurosurgery. We have treated over 100 patients so far in the country, and we're the only center in the nation for this type of interventions. And again, you have a hemifacial spasm patient. If they're not the candidate for microvascular decompression surgery, if they don't have blood vessel touching on the facial nerve, it sounds like blood vessel is always the culprit of those nerve facial pain conditions. You can have them come to my office for this. Or we also started to target sphenopalatine ganglion. So if you have headache patient here in the audience, you would hear this term called SPG block. What the heck is SPG? Sphenopalatine ganglion is one of the largest parasympathetic ganglion in our face, inside the sinus behind the middle turbinate. It provides this parasympathetic, which is yin, right? Yin and yang, right? Sympathetic or parasympathetic. Parasympathetic provides the innervation to all the blood vessels in the brain. When it's activated, you got a cluster headache, migraine, etc. So we also developed a way under endoscope to target this, and this is another video here. Basically, we're able to do this with now direct visualization. So it's much more, oh, here you go. It's much more effective. So all the treatment used to be very, very kind of a low success because you don't know where you're going. And then this is the approach I developed, that we are using endoscopes, go into the nose and deep behind the middle turbinate, we find the foramen where the nerve is, and boom, putting the medicine there. That's it. A headache patient coming in with one injection, like one time, 5 minutes, you get a month of relief. So this all started from that patient. And over the decade, I have built up a series of technology that's make available for our patient, for our community, as well as teaching the next generation of young patient to be able to help their own patients. And I still remember her, and that's my motivations to continue the clinical innovation pathway to provide for my patient. So am I happy now? Not at all. I continue to lose patients every year. Just a couple months ago, I was just sharing with my wife and my family. I said that it was a heartbroken, another one of my patients who in early 50s and ended her life. Not because we can't help her. Now there's another issue, is the healthcare issues. I think it's probably the same thing in our debates, is accessibility. For patient to have appointment with us, you have to wait, or entire country, average waiting time for you to see a physician is about 5 weeks. That's not a good care model, right? When the patient is suffering, and you would call the doctor's office and they tell you, like, I can't see you until next year. And how would you feel that? It's terrible, right? So I think the accessibility is another issue, which I will touch upon in the end. So over the years, I started to think more. I cannot be just a surgeon or interventionist just by doing procedures, right? And those patients are going to keep coming back. And you cannot, reduce the patient amount, the patient load. I started to think about, okay, what else can I do on the research side? I started to kind of try to understand, better in terms of what's the circuit underlying those patients, that they have a different presentations, but they all share a very debilitating conditions. So I came down to this pathway. It's called the trigeminal cervical complex in the brain that link all those ganglions I just introduced to you in the last few slides. The trigeminal ganglion, the SPG ganglion, there's many other ganglions. They're all connected together in our brain that providing you sympathetic and the parasympathetic and the sensory inputs to the brain, out of the brain, that manifested in various disorder. So I started to go back to the research with collaborations with my former fellows, now a faculty at VA and in Stanford, Dr. Qian. We started to kind of validate some of those hypotheses in mice, in animals, and to see whether we can actually, at the molecular levels, can help us understand better of the circuit, what's going on, why it happens to some patient. And can we treat them not just at the end of their journey, but at the beginning of their journey? And so with those kind of a research, we realized there are actually thousands of publications already over the years of the decades that are focusing on, a different target. In this way, it's the occipital nerve that people have really focusing on. Like, there's more than thousands of publications. And we have found a better research target, which is up in your cervical spine, called C2, dorsal root ganglion, where we believe it's a key player in this circuit, and it's a key player we can manipulate percutaneously, meaning that we actually have a way to access to it without opening up your brain. So my research of the last 2 to 3 years has been really focusing on this specific ganglion called C2, dorsal root ganglion. We dissect them out. You're trying to kind of target it for various conditions. And this is all my patient. We started to kind of modulation, long story short. And we found out that if you electrically stimulating this ganglion through a percutaneous approach, the headache gets better, the facial pain gets better. With that, we published our approach we call Q2 approach Because it was funny because it's at C2, right? It's a C2, and then my last name is Qian, so I call it Q2 approach, just for people to remember that, how can we target this C2? I feel like that's a mission, destined. I need to work on the C2 DRG, and I need to figure out a way that we can modulate its activities. And then this is kind of a technique note I published and one of my colleagues in the country to learn how to do it. But is that enough? That's not enough. And we also realize that we lack a tool for this target. So me and a bunch of engineers, we started to kind of develop a prototype for this for this target. And we come up with a neuromodulation device. We're conducting clinical trials right now at Stanford as to implant this device. It's kind of like a pacemaker for the nerve. We put a little device on the C2 GRG. The patient will turn this on 30 minutes every day. And we have seen some, I shouldn't talk about this too much, but we're seeing some very good results that if you do that, it's a modulation. Again, you're modulating the process, right? We know the circuit underlying headache and facial pain is abnormal. We don't know why, right? Again, we don't know why, but we understand why this is happening, what is happening, and then we're trying to use a very effective way to modulate, which is using electricity to modulate that. So this is really kind of my clinical focus and clinical research over the past decade. I did not mention that I also work a lot on other stuff, which I want to share with you as well. In particular, those three categories. In the middle category is really the wireless, powered device that I've been working on to revolutionize. I would say elevate our neuromodulating device to the next level. Because I'm a co-director of Stanford eWare, where we have connected to more than 80 labs. And a lot of very bright postdocs and PhD students and graduate students, they're interested in device development. We just actually published an article on Nature last week. We developed a very, very soft hair-like electrode that we can put into the brain. I mean, it's just like a hair. So it's very, very non-invasive. We actually can record activities from a single neuron, just like one neuron. And we're trying to make those into a device. Imagine for trigeminal neurology patient, I developed an approach that we can insert the wire at the corner of the mouse and go through and go behind the eyeball, go into the middle brain fossa. Because it's so thin, the device we used to have is too big, even though it has been done, but the patient don't like it. There's a CSF leak, there's a risk of meningitis. It's really hard for us to do that kind of procedure. But now with this new device, which is hair thin, we can just put it in and bury it underneath the skin. You can't even tell. You can smile, you can talk, you can eat. Wouldn't cause the issues. But we can power it with wireless control. That electricity, that wire can sense the trigeminal neurons when it fires, which is pain, and we can suppress it whenever it fires. So I'm very excited about that. And then I hope that in the next 10 years, we're able to get that device available for our patients. I'm also working on a new technology called non-invasive deep brain stimulations. I'm sure many of you know DBS, treating Parkinson's disease, right? But DBS is a very effective therapy, but it's very invasive. You have to drill a hole in the brain. You have to put the wire deep into the basal ganglion, and then you stimulate. You can treat Parkinson's. It's one of the standard care. If Parkinson's disease patient fail conventional therapy, you can do DBS. But it's very expensive. It's also has a lot of risk of surgical risk. Migration is always an issue. Infection is also an issue. So whether there's anything that we can come up with that's non-invasive. So 2023, about 2 years ago, Professor Grossman from MIT published a study called time interference technology. You basically put 4 electrodes on the top of head, 1 on the right, 2 on the right, 2 on the left. Both of them will generate an electric field in the brain, deep in the brain. They will deliver the electric current at a different frequency. That different frequency will give you a chance for 2 electric fields to overlap. That's called time interference. I would, I think if you're interested, anyone in the audience interested, you can Google search TI, time interference, DBS. This is the new trend, new technology. So when I saw that, I thought, this is really cool. And I look into the details. My PhD is really in electrophysiology and biophysics, so this is very natural to me. So my lab quickly adapted that technology. We started to make a device that can generate TI wave and then can modulate different function, different parts of the brain. And this is very, very exciting. That's me in the photo and wearing a little helmet. The helmet will have different holes. We pre-scan your MRI. We know where to put the electrode. If I wanted to modulate, for example, in hippocampus, that's for memory. And then if we do thalamus, we can do TBI patient. We can do chronic pain, because thalamus is where the relay station is. You can do many other brain regions, basically any regions you want. This is I'm really, really excited about that. I can share with you, Professor Grossman did in Europe for healthy volunteer to prove it's safe. Me and my group, we're applying for the first ever FDA phase 1 trial in the United States to treat chronic pain as well as TBI patient. It's in the process. I hope FDA, could be out of this government shutdown soon and could start to review our protocol, and then we'll get this going as soon as possible. Actually, yesterday I was in my lab as well. My wife knows. In the afternoon, I was spending the whole afternoon there trying to adjust the device, etc. I self-stimulate the front lobe, and I have my assistant to test my capability to solve math problems before and after. So I'm very, very excited about this TI non-invasive DBS protocol, because I feel like our patients really they're very vulnerable and sustainable to this healthcare system that it's expensive, difficult to access, and I think it really, the academics has a responsibility to lead this kind of new stuff and to provide better tools for them. I'll stop right there. And then I also mentioned earlier, again, my patients, right? This is, that they cannot have access to us, myself included. My patient, if they want to see me right now as a new patient, it won't be until next February. And that's just horrible, right? As a physician, you want to be able to treat as many patients as possible, but I also need to have a supporting system. I need to have an admin system to support me, to support all of us to make us available. So how do I do that? And then I was sharing this to our audience in one of our lectures to the public a few months ago. And then two people from the audience, there happened to be an engineer from Google's. They said that, can I help you? So I said, well, sure. I would love to work with you guys to address this problem, but can we address this problem? And they're, one of the engineers from Google DeepMind, and he said that, what do you want? Like, what do you think is the most important thing? I said, well, if you can clone me, right, and you put my digital clone in the clinic, I think that could be very helpful. And they said, okay, let's do it. So they cloned me. So, obviously they can't clone me how to operate, how to do procedure, but they basically cloned my clinical reasoning capability. So over the 6 months or so after we first met, they came up with a clinical reasoning model, a fine-tuned model based on large language model, with my own experience and analytical capability in my cases, etc. They kind of mimic how I would interview a patient. And then we validated at Stanford, Mayo Clinic, UCSD, as well as University of Toronto. Very recently, we came out with the very early preliminary data. The AI agent can interview the patient via a natural voice-based conversation. It can collect medical information better than humans do. It actually can form as accurate differential diagnosis as humans. I was literally jumping out of a chair when I saw that results. So that's another way how being in Silicon Valley, that working with technology people, trying to address, unmet medical needs. And that I'm very passionate about that. I hope this doctor models can benefit the country because I plan to make open source so that you can use it to digital clone of Dr. Boyton, right? And Dr. Mataki, right? And this is a very, very interesting era of our life, and I think we're very lucky to be in this area. I mean, you're at Berkeley, you're next to UC Berkeley. We're at Stanford, and then we're surrounded by those technologists in the country. I think it's very important for providers to have a voice at the table. We cannot let the technologists to lead this change that we have no voice in it. Because all the technologists out there are saying doctors going to be replaced, nurses going to be replaced. How do you feel about that? Do you agree with that, right? But I think that, you can disagree or you could be not happy about it, but if you do not participate, you'll be eliminated in the wrong way. Again, they don't understand. For many conditions, pain included, it's very complex. You cannot let's say you cannot digitalize a pain patient. You can't, right? There is no score that you can describe a patient. Maybe diabetes, even diabetes. Hopefully I don't offend any endocrinologists here, But even with that, there's a lifestyle, there's genetics, there's emotion part of it. There's lots of things about it, right? But for pain in particular, it's such a complex neural matrix representation. It's such an interplay between psychological, social, and biological. And I think it's really important for the technologists to keep in mind that you don't want to do that. With that, I have built this headache and vision program at Stanford. It's a truly multidisciplinary approach that serve our patient in the country. I know I'm running out of time. So I'm gonna stop soon. And this is another patient that wanted to ask me to take a photo for her. She's a writer, so she said I'm gonna write this in my next masterpiece. I was very happy. I said, okay, I'll show this to our patient, to my talk in the future. She benefited from this comprehensive pain program. So I have a lot of reference and etc. So thank you for the audience. And if you have questions, we can chat. I do not think I have time for questions, right?
I think not.
Okay.